How are you doing?
Good morning and welcome to today's Oversight hearing. First, I want to extend a thank you for everyone who is participating, particularly our witnesses. I appreciate you being here. I want to begin by recognizing the work of those in the organ procurement world and say, look, it's vital work, but our job here is to understand. We actually started last April sending out requests for information. And with the investigation, we've had some very, sometimes uncomfortable bits of information come in. Each organ procurement organization is certified by CMS and operates exclusively within a designated service area, giving it unique and highly consequential roles in that community. These organizations provide life-saving services to thousands of Americans, but that mission does not place them above accountability. Following the committee's April request for information, we received responses from several whistleblowers across the country. In reading the testimony that's come to us, we're trying to understand where the fragility is. And I'm off script, but this is someone who spent part of their weekend reading these things. Is some of it at the hospital level? Is some of it at the advocacy level? Is it at the procurement organization level? Is it at the CMS level? Help us understand. And help us also understand where we need to extend our investigation. But ultimately, for all of us up here, we want to fix things. Is it ultimately coming to a new scoring system? We've been trying to read about the differentials between lung procurement and kidney and some different scoring models that are used for that procurement and placement. Help us understand where we should take this. Look, we look forward to the testimony from our witnesses. And I will actually ask my questions at the very end. But between now and then, give us the tools, give us your stories, help us understand. And with that, Ranking Member Swill.
Good morning, everyone. I join in Chairman Schweikert's in convening this very important hearing on accountability within the organ procurement organizations, or OPMs. This is not a partisan issue. It is not an abstract policy debate. This is about the life and death of more than 100,000 Americans who are waiting for a transplant right now. For years, independent reviews, including federal audits and Government Accountability Office reports and HHS Inspector General's investigations, have warned us that America's organ procurement system is underperforming, to say the least. So some OPMs do extraordinary work. Others lag far behind with low recovery rates, poor management practices, and preventable lapse that could have saved lives. These failures are not theoretical. They have led to organs not being recovered because OPMs do not show up to hospitals in time or lack trained personnel, breakdowns in testing, documentation irregularities, and the list goes on and on. These systemic failures are sometimes described as organ procurement crisis. It is a crisis rooted in bad actors, but it's not bad actors alone. I believe that it is also a result of an outdated accountability structure that we in Congress could do something about. I come from Alabama, and I represent families who give and families who grieve. I believe that there are three simple principles for this hearing: transparency, accountability, and equity. When those principles are missing from organ procurement and autopsy practices, trust is broken and lives are harmed. There are several reported cases and lawsuits out in Alabama that illustrate why this committee hearing today is so important. Families of people who died when incarcerated in Alabama have reported receiving loved ones' bodies with internal organs missing and have filed civil lawsuits alleging that these organs were retained or used without consent. Multiple news reports and national outlets have documented these families' complaint. These families have demanded answers and criminal investigations from the state officials, and they look to Congress to try to do something about it as well. It is also important to place Alabama's cases in a national context. In recent years, bipartisan Senate and House inquiries, as well as CMS and HRSA reviews, have documented systemic accountability issues and gaps. I believe that we must do more than just talk. We must do something about it. OPMs hold a unique position. They are federally designated monopolies, if you will, tax-exempt organizations entrusted with responsibility that no one else can perform. Congress has a duty to ensure that public trust is deserved and not assumed. We must provide vigilant oversight and implement reforms that will strengthen performance, modernize oversight, and protect patients and their families. I want to stress that this is not a partisan conversation. Both Democrats and Republicans have expressed deep concern about the failures within the OPM system. Administrations from both parties have proposed reforms, issued updated regulations, and called for greater accountability. And we must do both. I also want to highlight and hope that we will talk about the disparities that exist in organ procurement. Black Americans are 3 times more likely to suffer from kidney failure, yet they wait longer for a placement on transplant lists and are less likely to receive a transplant. Communities of color face delayed referrals, lower access to transplant centers, and inconsistent communication from OPMs. Equity must be centered to ensure that we actually get it right. No community should be left behind simply because of where they live, how their hospital is resourced, or the color of their skin. Now, we must also recognize that all of these failures are happening in a time when my Republican colleagues have passed a bill that has gone to weaken Medicaid and Medicare and cause millions to lose and reduce their insurance. The bill that was passed in July created new barriers for patient seeking timely organ failure treatment and transplant referrals. Organ transplantation does not happen in isolation. It depends upon a stable coverage, chronic care management, and early detection, all of which become harder when patients lose access to affordable health care. Any policy that increases the ranks of uninsured inevitably worsens the transplant outcomes. In conclusion, accountability for OPMs is not optional. I believe it's essential. Lives depend upon us getting this right. Today, as we hear from witnesses and examine the failures of the current system, I hope that we keep one thing in mind. Every improvement we make has the potential to save a life, to shorten a family's grief, and to honor the generosity of donors whose final act is a gift of hope. Let us work together, Republicans and Democrats, to ensure that America's organ procurement system finally meets the standards our patients deserve. And with that, I yield back.
Thank you, Ms. Well. Now we're going to introduce our witnesses. Heather Knuckles, all right, a citizen of Missouri and Chairman Smith's constituent, who's here to tell us the story of her mother's organ transplant. Nyckolleta Martin, a former OPO employee, Jennifer Erickson, Senior Fellow for Organ Donation Policy, Federation of American Scientists. You want to Introduce yours.
Emily G. Emily G., who is Senior Vice President for Economic Policy and Senior Fellow for Health Policy at the Center for American Progress. Welcome, everyone.
Ms. Knuckles, and to everyone, you have 5 minutes. Your written testimony will become part of the permanent record.
Good morning, Chairman Smith, Chairman Schweikert, Ranking Member Sewell, members of Congress, or members of the Oversight Subcommittee. My name is Heather Hollis Knuckles of Imperial, Missouri, and I'm here today to discuss my mother's fatal liver and kidney transplant in 2022. 7 years ago, my mother was diagnosed with fatty liver disease, which evolved into cirrhosis. In November of 2021, as the cirrhosis advanced, my mother became bedridden while my husband and I provided daily intensive care. By mid-2022, her kidneys were failing and she was placed in a nursing facility awaiting a healthy donor liver and kidney. Our prayers were answered on October 29th, 2022, when a donor match was found. Coincidentally, this was my wedding day, and I remember my mother smiling at me and saying, "I'm so glad I'll get to be a part of your life going forward. I can't wait to be a mother-in-law." She held my hand, looked me in the eyes, said, "I really hope this goes okay because I wouldn't want to die or anything." We reassured her it would go well and her new life would begin. It was the happiest day of our lives. Little did we know, the nightmare was just beginning. On October 30th, 2022, my mother underwent the liver and kidney transplant at Barnes Hospital in St. Louis with organs procured by Mid-America Transplant. The day following surgery, she was happy, alert, and couldn't wait to be home to see her pets, family, and friends. On November 3rd, transplant surgeons informed us that the donor liver contained high-grade metastatic cancer that was not reported on the donor records from UNOS, but was discovered by the transplant hospital Barnes after transplant procedure was completed. We were informed this was a very deadly form of cancer, and if it were to spread, she wouldn't be eligible for treatment. Our dreams were shattered. Fear and sadness washed over my mother's face. She was relisted for transplant. Surgeons decided to not replace the donor kidney, even though its condition was questionable due to a large cyst at the time of transplant. My mother underwent a second liver transplant on November 8th, 2022. She was extremely fragile afterwards, hallucinated for days, and suffered delirium. Occasionally, her wrists were restrained for safety. This was heartbreaking. By late November, she was transferred to the St. Louis Rehab Institute, and she remained unable to walk and was jaundiced. Tests revealed the donor kidney had a blockage and was dysfunctional. 2 attempts to insert stents in the donor kidney failed, and it would only survive with a nephrostomy bag. On December 16th, my mother was readmitted to Barnes Hospital, placed on a feeding tube with a nasogastric tube that removed bloody gastric acid. She was developing a large solid mass on her lower abdomen. She became emaciated, failed to absorb her tube feeding, and required the hospital to pivot to an IV feeding. She was communicative but could only whisper and had trouble holding her eyes open. We never received an explanation for her rapid decline. My father and my husband and I both reached out to transplant teams seeking answers. One recommendation from the liver team administration was to have hope and prayer, while my mother, unbeknownst to us, lay dying. Please bear in mind my mother's body never rejected the organs. On January 9th, 2023, my mother was transferred to the ICU and placed on life support. The next day, the transplant surgeon informed my father and I, based on the appearance of a CT scan and fluid testing, the liver was cancerous. This confirmed the doctor's earlier suspicion that the cancer was transplanted from the first liver. Friends and family stayed at my mother's bedside daily, and per her living will, my father made the gut-wrenching decision to remove my mother from life support Friday, January 13th, 2023. We said our final goodbyes, and she passed at 5:40 p.m. Per UNOS records, the donor was hospitalized and placed on life support for 6 days. A CT was performed, however, no cancer cells or no abnormalities were reported. The radiologist report states conventional hepatic arterial anatomy, no liver surface nodularity or steatosis. 5 days post-transplant, Barnes pathology revealed the deadly cancer that killed my mother 2.5 months later. Barnes pathology notes state metastatic, poorly differentiated adenocarcinoma involving donor gallbladder, present as scattered subserosal tumor and prominent intravascular deposits favor metastatic gastric adenocarcinoma. On one hand, UNOS considers the donor eligible, yet 5 days later, Barnes pathology reveals high-grade metastatic cancer. Following the passing of my mother, we suffered nearly 3 years as this horrific ordeal was ignored. And if OPOs are not held accountable when situations like this occur, they won't feel compelled to implement enhanced safety standards or procedures for organ recipients. No one should ever have to experience what my mother and our family has endured. It is time for the entities responsible to be addressed. My request to this committee is to use the levers within your jurisdiction to address the importance of donor screening prior to transplant. As a recipient, my mother had to undergo rigorous testing, even checking for cavities prior to becoming eligible for transplant. Yet the donor, who we now know had cancer, was somehow eligible for harvesting, and this does not make sense. Chairman Smith, Chairman Schweikert, Ranking Member Sewell, members of the committee, I thank you for your time and vested interest in my mother's horrific transplant case. I'm willing to answer any and all questions you may have.
Good morning. Chairman Smith, Ranking Member Neal, Chairman Schweikert, and Ranking Member Sewell, members of the subcommittee. Thank you for the essential work your committee is undertaking to bring transparency to the corruption, dangers, and systemic deception embedded in the organ procurement industry. I previously worked as a surgical preservationist in an OPO. My role there was to assist in the safe recovery and preservation of life-saving organs for transplant. From my firsthand experience, it appeared that my former employer was exploiting a regulatory loophole to advance its metrics and increase Medicare reimbursements at the expense of organ donors and their families, who I believe were being misled and taken advantage of. In 2021, TJ Hoover was brought to the hospital in cardiac arrest. As a registered organ donor, his family agreed to honor his wishes. TJ had remained unresponsive for several days, regaining consciousness during his cardiac catheterization. Immediately upon waking, he was paralyzed and sedated. Hospital staff described the situation as inhumane and akin to human euthanasia. The cardiologist present advised TJ should have never been given a grave prognosis with no meaningful recovery, given his reflexes present. Despite being alerted to these concerns, the OPO staff returned TJ to the ICU without performing the required neurological exam that should have been repeated. Even more alarming, and to the best of my knowledge, the family was never informed that TJ had regained consciousness and had shown meaningful emotion and purposeful movement. Under my former employer's own protocol at that time, the case should have been halted immediately once neurological function improved. The failure to do so represents a profound breach of medical standards and ethical responsibility. Following TJ's case, an organ operations manager convened a staff debriefing. It quickly became clear that my former employer was attempting to contain the situation. Despite multiple staff urging reporting the case to appropriate authorities, we were told the OPO would handle it internally. Our access to TJ's medical records were restricted. We were silenced. This experience resonated when I read this committee's letter to the New Jersey Sharing Network. The parallels between those whistleblower allegations and my own are unmistakable. Patterns of concerning organ recovery practices, document destruction, and retaliation against those reporting legitimate concerns, highlighting systemic failures that demand urgent accountability and reform. After I came forward as a whistleblower, the Health Resources and Services Administration launched an investigation into my former employer. In just 89 days, there were 103 cases in which the organ donation process was initiated in error. What is even more frightening is that the investigation only examined cases in which the patient survived. We have no way of knowing how many times organs may have been recovered from patients who would have otherwise lived. The scope of this risk is staggering and underscores a systemic failure that cannot be ignored any longer. This OPO's mission under their current leadership is described as one focused on restoring public trust, enforcing ethical and medical standards, and prioritizing donor and patient safety over metrics. As far as I'm aware, the administrative leaders involved in the decisions surrounding TJ's case are still serving in leadership roles at that very OPO. The organization overseeing donation has not admitted wrongdoing, nor has it shown any compassion, remorse, or any commitment to real change. This lack of accountability is precisely why organ donation in some states remains unsafe. The pursuit of metrics can never supersede the fundamental mission of saving lives through transplantation, nor can it justify misleading the families who are already in the depths of grief and counting on their loved one's donation to make a difference. OPOs must be held accountable for wrongdoing so that Americans can trust the organ donation is safe, ethical, and worthy of their generosity. I urge this committee to do all that it can to continue its investigations into OPOs and to UNOS. I believe in organ donation, and I've devoted much of my life to it. I am now pleading with Congress to do everything in its power to make this process safe by working with HHS, CMS, and HRSA to identify and replace dangerous actors and to protect our most vulnerable patients.
Chairman Smith, Ranking Member Neal, Subcommittee Chairman Schweikert, and Subcommittee Ranking Member Sewell, and members of the committee. Thank you for shining a light on this public health crisis that is leading to unnecessary deaths every day across the United States, the failures of the federal government's own organ contractors. I am testifying today in honor of my father, Commander Donald Erickson of the United States Navy. My father died of organ failure, the result of his military service in Vietnam. Chemical exposure claimed 3 of his organs 40 years after the war ended, and I was one of his caretakers. To sit next to a loved one through surgeries and hospitalizations and to hold their hand through their final days is to know the true cost of the organ waiting list. These are grueling deaths, and knowing that most of them are unnecessary is what drove me to work with anyone willing to engage on reforms across the most recent 4 administrations and with 4 congressional committee investigations. Investigations have exposed that the harms fall not only to patients on the waiting list, but also to Americans who are in ICUs because there's been a tragic accident, overdose, or other event that means they're being approached by organ procurement organizations, OPOs, and asked to say yes to organ donation. Americans are generous and overwhelmingly supportive of organ donation, but as explosive whistleblower accounts and investigative reporting have laid bare, many OPOs are abusing this sacred trust. We are in the midst of a national organ harvesting crisis, and corruption at OPOs is the problem. Taxpayer-funded OPOs operate with virtually no accountability, and OPOs have pressured grieving families and, in the most horrifying cases, targeted patients who aren't even dead. Whistleblowers have shared they've been trained to target inexperienced physicians, especially in rural America and hospitals where doctors haven't seen these types of cases, in an effort to destabilize patients through the over-administering of comfort meds, such as fentanyl. This summer, the longest-serving transplant coordinator, Charles Bearden, passed away. And before he died, he shared at some points in his career, he literally covered a patient with his own body to stop dangerous OPOs from harming patients who could otherwise survive. Members of Congress have described the findings as something from a horror movie, and they are not wrong. The line between organ donation and organ harvesting is consent. No family would consent to a loved one being wheeled into an OR to have their organs removed when they could survive. Yet that's what's happening across the country. HRSA outlined rampant abuse from Network for Hope, the OPO operating in Kentucky, Ohio, Indiana, and West Virginia. And this committee issued a damning oversight letter informed by nearly a dozen whistleblowers, writing that activities performed by New Jersey Sharing Network amount to not only extreme abuse of public trust, but also potential violations of law. The details are chilling. A patient who'd been declared deceased reanimated, and according to information obtained by this committee, the CEO told staff on site they should proceed with recovery. Several whistleblowers alleged documentation regarding the case was deleted or otherwise manipulated. Congressional investigations have shown out-of-sequence organ allocation, coercion in obtaining consent, and patient abuse. Additionally, the committee has started investigating the misuse of jets and other uses of taxpayer funds, and I am grateful that this committee is following the money in this multi-billion-dollar industry. IRS 990s show OPOs have transferred more than $500 million to related organizations where uses of taxpayer funds get pushed even further into the shadows. Multiple OPOs have financial interest in tissue processing companies, including ones who do business internationally and in the Middle East, raising even more questions about who is getting rich off the backs of generous Americans. I believe in organ donation. There are OPOs that do the job with integrity and many brave frontline workers who've sounded the alarm, only to have been silenced and retaliated against when they tried to protect patients. The need for action is urgent. We can no longer expect the American people to blindly trust contractors who endanger their lives. And the fixes are as apparent as the problems are abhorrent. Any OPO who has abused the public trust through harming patients, misleading families, or misusing tax status or tax dollars must be immediately replaced. and prosecuted to the fullest extent of the law. The Trump administration, responding to bipartisan calls from Congress, showed its willingness to act by replacing the OPO in South Florida. I hope this investigation, with its extensive documentation and whistleblower accounts, can help Congress and the administration take similar actions to replace Network for Hope. And if allegations are proven true, New Jersey Sharing Network, along with any other OPO that endangers patients. For anyone watching this hearing, the safety of your family may depend on the continued investigation of this committee and the actions of the administration to replace dangerous contractors before you or a loved one is ever in a hospital room with a corrupt or negligent OPO approaching.
Good morning. Thank you, Chairman Smith, Ranking Member Neal, Chairman Schweikert, and Ranking Member Sewell, and members of the subcommittee for inviting me to testify today about the need for stronger bipartisan oversight of organ procurement in the United States and about how comprehensive health coverage is essential to a well-functioning healthcare system. Above all, I want to thank the subcommittee for investigating the degree of abuse, fraud, and waste in the U.S. organ donation system. I hope that recent alarming incidents reported in the press, findings by the HHS Inspector General, and the evidence discussed at this hearing will spur Congress to demand tighter oversight of organ procurement organizations. However, I also want to note that there is no need for HHS to wait for congressional intervention. The Centers for Medicare and Medicaid Services is already responsible for certifying OPOs. CMS has the authority to terminate an agreement with an OPO that no longer meets the requirements of certification, as it did in September for the OPOs serving South Florida. HHS, CMS, and HRSA have a responsibility to ensure that OPTN and the OPOs are acting in the public interest, and OPOs must be held accountable for putting the well-being of patients first and for being responsible stewards of taxpayer funding. But at the same time, other threats to Americans' health are looming. As a consequence of the policy choices made by this Congress, about 14 million more Americans will be uninsured by 2034. The so-called Big Beautiful Bill slashed federal healthcare funding by $1 trillion over the next decade. Evidence from Medicaid coverage expansions demonstrates that health insurance is important for health and other outcomes. Having health insurance is associated with a decreased likelihood of unmet medical needs, greater use of preventive and primary care, improvement in financial well-being and reduced medical debt, and lower probability of eviction. Beyond causing millions to lose coverage, Medicaid cuts will squeeze state budgets and strain hospitals and other healthcare providers around the country. Hospitals will be left to cover the costs in the form of uncompensated care. Before the law's passage, over 300 rural hospitals in the United States were already at immediate risk of closing due to their financial conditions. In addition, this Congress has turned down multiple opportunities to extend expiring financial help for people who buy coverage on their own. The enhanced premium tax credits for ACA marketplace plans expire on December 31st. Consequently, the average premium payment among the more than 20 million people who receive subsidies is set to more than double for 2026. It is not too late for Congress to improve affordability if it can find the will to do so. Comprehensive health coverage is important for access to organ transplants. The Affordable Care Act's coverage expansions have generated broad-based gains in health insurance coverage. As of 2024, the insurance rate for the total population was about 8%. The number of organ transplants has also been trending upward. Notably, the increasing number of listings suggests that gains in health coverage may be providing patients with options they otherwise would not have had. One study found that Medicaid-insured waitlist registrations and deceased donor transplants had increased in states with Medicaid expansion. Americans who lose coverage may have greater difficulty being listed for transplants. It is rare for transplant recipients to be uninsured, in part because patients may qualify for special coverage. Another major reason is that transplant centers typically weigh both medical and non-medical factors in evaluating candidates for transplantation. Would-be recipients have been refused transplants because of a lack of insurance or shaky finances. Beyond cost and proximity to the procedure, health coverage is vital to transplant recipients' access to follow-up care, care for complications, and lifelong immunosuppressant drugs. If proposals under discussion in Congress are implemented, the health coverage landscape could turn far worse. Specifically, policy changes under discussion would harm people with pre-existing conditions. Some lawmakers have suggested pushing enrollees into lower value plans with higher deductibles, replacing comprehensive coverage with health savings accounts, or relegating the sick to high-risk pools. That would be a grave mistake. The very point of health insurance is to pool risk broadly, giving people financial protection against catastrophically high medical bills. The ACA's rules are critical to ensuring a functional market for affordable, comprehensive health insurance for all Americans, including people with organ failure. The health of all Americans depends on affordable, comprehensive access to insurance. Thank you. I look forward to your questions.
Chairman Smith, first question.
Thank you, Chairman Schweikert. As someone who has a family member that was a recipient of a heart transplant just in the last few months, I personally appreciate this committee's ongoing work regarding OPOs. It is so incredibly important that Americans have trust, that they have trust in our nation's organ procurement process. That is the only way that we can ensure that folks will continue to donate. News of misdeeds or a growing lack of faith in OPOs can suppress participation in the system and hurt those who need these life-saving transplants. There was more than 48,000 people who had an opportunity to extend their life through donations last year alone. Ms. Knuckles, I'm grateful to have a native of Missouri from God's country, as I refer to it, testifying before our committee, but I'm deeply saddened about why you're here. The story of your mother's liver transplant is absolutely shocking and heart-wrenching, and a clear example of the breakdown in the standards of healthcare that your family and every family should be able to expect. Without asking you to once again recount or relive the details of your family's terrible experience, I'm curious to know, has the tax-exempt Mid-America transplant acknowledged the horrific failures that occurred with your mother?
No,
Not at all.
no, not at all.
Shameful. Is there anything that the committee can do to ensure that what happened to your mother doesn't happen to anyone else?
Yes, yes. Please consider legislation ensuring that donors receive the most rigorous screening possible prior to organ harvesting. Recipients like my mother have to undergo multiple tests to ensure eligibility to receive donated organs. Other than needing the liver and kidney, my mother was healthy and cancer-free. In the meantime, the donor, who was on life support for nearly a week, had aggressive cancer that was reportedly not detected on a CT scan. That was plenty of time for thorough testing to occur. I respectfully request an investigation into my mother's case and other cases so that lessons may be learned to help ensure this horror never occurs with any other recipient or other family.
Thank you. As part of this committee's ongoing investigation into tax-exempt OPOs, we learned about troubling allegations regarding Life Alliance Organ Recovery Center in Miami. We voiced our concerns about the Medicare fraud in a letter to that organization demanding additional information. And in turn, the Trump administration moved to decertify them. After speaking to what is now over a dozen different whistleblowers, the committee recently learned of troubling allegations from another OPO, New Jersey Sharing Network. Ms. Erickson, based on your experience, what impact will congressional oversight have on bad actors in the OPO space?
The Trump administration has showed that it's listening to these congressional investigations on this issue. And I hope that based on HRSA's findings and your ongoing investigation, that CMS and HHS will take immediate action and replace the dangerous Kentucky-based OPO Network for Hope. And if allegations from these dozen whistleblowers are proven true, they should take the same action and immediately replace New Jersey Sharing Network.
If calling out the misdeeds of these OPOs is step one, step two is reforming the system so that it is safe, It's accountable to patients and taxpayers, and it's trusted. Ms. Martin, this committee has already begun thinking through policy options that clarify the OPO certification process, implement penalties for violating CMS regulations, and ensure that OPO data belongs to CMS so agencies can have better insight into OPO behavior, in addition to giving regulators better tools in implementing a clarified process of certification and decertification. What sort of reforms would further improve OPOs so folks are willing to donate and participate freely in the system?
Honestly, I think right now all eyes are on Kentucky. As a Kentucky citizen and still working in the healthcare system, many people have come to me and have said, what are we doing about this? What's going to happen to Network for Hope? Where's the accountability? So I think this has to start from regaining public trust, and the only way to do that is to have transparency and accountability, and for Congress to continue working with other legislative bodies and law enforcement specifically to make sure that these people are taking accountability for what they've done so that doesn't happen in the future. And then we can show the public, we see the problems, we're working on them. The public should have more informed consent. They should truly understand what they're signing up for when they sign up to be an organ donor, because organ donation is so important and we need it so badly. Thousands of people are dying, but also thousands of people are taking their name off the organ donation registry. So we have to fix that.
Thank you all so much for being here on such an important topic. Thank you, Mr. Chairman.
Ranking Member Sewell.
Well, first of all, thank you so much for sharing your stories. I hope you know that we up here do take very seriously our oversight responsibility. And as the chairman said, we have been very much involved in trying to make sure that we're sounding the alarm for some of the bad actors that are going on. More than 100,000 Americans are languishing on organ wait list. In Alabama, we've seen the problem up close. Last year, it's a disturbing report that I talked about in my opening remarks about incarcerated people having their organs removed without the consent, their consent or their family's consent. And this summer, the New York Times wrote a chilling account of a young Alabama woman whose heart was still beating when the organ procurement surgery began. Health Secretary Kennedy has promised to remove dangerous OPOs and to replace them with others. But Ms. Erickson, can you tell this committee what we can do to ensure that patients are safe?
Thank you, Ranking Member Sewell. It's absolutely critical that Congress keeps going with its investigation. You're right, this is a nonpartisan issue and affects people across the country. And Ms. Martin is right, all eyes are on Kentucky. Congress can urge the health secretary to follow through on his promise and remove known dangerous OPOs, such as Network for Hope and New Jersey Sharing Network, based on these allegations if proven.
Dr. G, you so eloquently talked about why access to affordable health care is critically important. Can you talk a little bit more about why it's so important that we extend these the tax subsidies in order to make sure that the 20+ million Americans continue to have health insurance coverage, and how that impacts organ procurement?
Because of the big, beautiful bill, in addition to the expiration of the enhanced premium tax credits at the end of this year, about 14 million more people will be uninsured by 2034. In particular, the tax credit extension will cause about 20 million people who receive subsidies through the ACA marketplaces to see their premiums more than double on average. And unless Congress extends those subsidies, they'll expire at the end of this year. That affects everybody who has coverage to the marketplaces, regardless of whether they have subsidies, because when the cost of insurance goes up, people who are younger or healthier tend to go without insurance, which makes costs more expensive for everybody else. Insurance is a requirement for transplant, many transplant centers across the country, because transplant centers choose to give donated organs to the patients where they'll have the greatest chance of success.
Great. Ms. Martin, you worked at an OPO. And so can you tell us what reform, if you could just single out one type of reform that would actually make a difference in saving the lives and also encouraging this amazing gift of life that people are giving? I think that the trust has been eroded, as you have said. And so what is, if you could just have a single reform, what would that reform be?
I think most importantly that right now, a lot of people feel like OPOs are kind of like vultures, for lack of a better term. I feel like families are pressured. They're not included in their loved one's care or decision-making. I feel like making a transparent, informed consent process would be appropriate in allowing the families to have more of a role in making these decisions and being supported better while they're making those decisions for their loved ones. I feel like that would help to improve public trust. And then again, also holding these people accountable. The dangerous OPOs need to be taken, out of the process.
Well, the horrific tales of the incarcerated people in Alabama and what happened to those families is just outrageous. Mr. Chairman, I'd like to enter into the record an AL.com article entitled Another Case Over Organs Missing from Prisoners in Alabama to Go Forward, Nothing Short of Robbery. Thank you. I think it's important that all of you know that this is truly a bipartisan issue and that we must get to the bottom of this in order to make sure that there's transparency and accountability in the organ procurement industry. And I make a commitment to work with my colleagues across the aisle to do something about that. And we will keep our eyes on what's going on in Alabama and make sure that my state does what it needs to do. But I think it's critically important that that HHS use its authorities to actually get rid of bad actors and do so. Having said that, I yield back the balance of my time.
Thank you. Pursuant to committee practice, we're going to go to 2-1. And Mr. Bean, you have 5 minutes.
Mr. Chairman, thank you very much, and good morning, Ways and Means Oversight panelists. I am truly sorry you come under the circumstances of which you come. I'm a member of the Oversight Committee. I'm a member of Congress. I'm a member of Ways and Means, and I'm used to reading about waste, fraud, and abuse. It's rampant throughout the federal government, but today there's 2 words I'm going to add to it in reading for preparation for today's hearing. It's shocking. It is shocking, and I'm so glad the cameras are watching, and I know C-SPAN is watching. America will be shocked when they find out what's happening behind these organ, just the way that we harvest organs and give organs to families and breaking hearts. Ms. Knuckles, Ms. Martin, I'm truly sorry, and it is shocking. It's also, I'm going to use a word you don't hear very often. It's evil. It's evil to rob families of the hope, to mislead them, to take organs before any organ should be taken. I'm really sorry. So I've got a picture behind me, and I want to ask Ms. Erickson, can you explain what I'm looking at with this picture behind me, Ms. Erickson?
Yes, Congressman. According to a whistleblower, those are boxes of human organs that are sitting on shelves, including human pancreases.
So pancreas. Now, if you donate a pancreas, shouldn't they go directly towards somebody in need of a pancreas?
Yes, sir. That's what families agree to.
So why aren't they going? In fact, I know why they're going, because there's a loophole in the law that says that
Yes.
you can use them for research. Is that correct?
Yes, sir. In 2020, CMS finalized a new regulation that said that OPOs only get credit for organs that are actually transplanted. But the loophole allowed them to declare credit for pancreases that they said were recovered for research.
So the people that donated these organs thought they were going to save a life or do something big. Have we, as CMS, defined research or put any timeline on what research is?
No, sir, they have not.
How many pancreas do you know have been harvested since 2020?
Over 7,000 across the United States.
Is there any, do we know the data that came from the research? Do we have any info that these pancreases were actually used for research?
Sir, they were not. Since 2020, islet cell transplants have remained flat, while pancreas harvesting has exploded with no proof at all that they were used for research.
the investigation, and thank goodness the Oversight Committee, I want to give kudos to them. The reading is again, shocking and evil. It showed that on a single day, the New Jersey sharing network threw out 100 pancreases after federal agencies started investigating this practice. Ms. Erickson, what does that mean for patients? They threw them away. What does that mean for patients? 100.
It means that 100 families in New Jersey, on the worst day of their life, because they lost a loved one, a wife, or a child to a car accident or some other injury, said yes to organ donation. They were lied to, and their loved ones' organs were cut out and left on shelves to exploit a CMS loophole. And Ranking Member Sewell, this happened to hundreds of patients in Alabama too, and I'm happy to send you that data.
Our report shows our Inspector General found examples of OPOs, organ procurement organizations misusing Medicaid dollars on everything from sporting events, limousines, retreats, 5-star retreats, breaking the law on their nonprofit status. Ms. Erickson, an OPO CEO, Tom Moan from One Legacy in Los Angeles, gave a presentation about money in organ donation. He suggested that in America, it is the OPOs that hold the purse strings and that they only need the acquiescence of payers. Is that correct?
Yes, sir, I've seen that presentation, and OPOs have clearly acted like they are in charge, inflating their costs with million-dollar salaries, such as that of Mr. Moan, and executive perks that have nothing to do with patient care.
Who pays? Who is the payer when it comes to organ transplants?
The largest single payer is Medicare, so the taxpayer.
And that's us. And that's us. Mr. Chairman, thank you for shedding the light. For everybody with the camera or watching, thank you. And if you're in media, this needs to be on the front page of every newspaper and on every newscast, that there is waste, fraud, and abuse, and it's shocking and it's evil. So, Mr. Chairman, I look forward to working with you to restoring trust. This needs to be a place of hope, of saving lives, and not of the abuse and the shocking evilness that we've seen. I yield back, Mr. Chairman.
Thank you, Mr. Bean. Mr. Young.
Thank you, Mr. Chairman, for holding this hearing today. Thank you to our witnesses as well for being here. And I want to also thank in particular the whistleblowers who are here today. The two of you before us really took a great personal and professional risk in coming forward. You've endured just incredible pain and perhaps even professional consequences as well. But just know that your courage in coming forward today is certainly inspiring to me, and I know to my fellow committee members as well. To give the gift of life, to donate an organ, is an incredibly selfless act. And for many, it's their final act they will ever make on this earth. The public and Congress have put our trust in organ procurement organizations to coordinate the identification, preservation, transportation, and transplantation of viable organs. Unfortunately, it's clear that there are bad actors who have misused this trust. I'm thankful that the Trump administration decertified one such bad actor in September after concerns were raised about safety and patient safety and staffing shortages. More recently, this committee sent a letter to the New Jersey Sharing Network raising concerns compiled from nearly a dozen whistleblowers that include Medicaid fraud, research fraud, evidence manipulation, failure to obtain donor consent, skipping people on the organ wait list, and more chillingly, a cover-up in a case where organs may have been harvested from someone who still showed signs of life. Ms. Martin, in your testimony, you say that there were striking similarities between the allegations in this letter and the organ procurement organization where you were formerly employed. Can you go into more detail on those similarities, and what do you find most concerning?
Absolutely. So I'll give you an example of one of the really dangerous organ procurement processes that are happening with pancreases. Even just a month ago at the hospital that I work at in Kentucky, one of my personal patients was in the ICU, and I was part of her honor walk. They went on to recover her kidneys and pancreas for research. The kidneys were intended for transplant. This patient had failing kidneys and was in multi-system organ failure, had an advanced age in her late 60s. We had ways of knowing that that patient probably should not have been a donor, and her loved one should never bring in hope that she was going to go on to save lives. So this is part of the problem, right? We're taking the pancreas for research and it's counting as a full donor for our OPOs. So processes like this, we're not allowed to speak out about. And whistleblowers like me, if we have a problem, we're being silenced immediately. So that's part of what, it's very similar for me. I'm not sure if anything happened to those whistleblowers like it did to me, but I feel like it just kind of all goes back. Who's making these decisions? How did we get here?
And can you elaborate more on a recent concerning donation after circulatory death, or DCD, cases in recent years?
Can you repeat that question?
Can you elaborate more on a recent concerning donation or after circulatory death, or DCD, cases in more recent years?
Well, there's been several. The Attorney General in Kentucky is actually investigating several situations that are far worse than TJ Hoover's case, honestly. I think a lot of the problem is that we are not providing the family with updates on actual neurological function and just those kinds of problems where we're using medications to chemically, sedate and paralyze patients. Like, we're never really giving patients a chance, and that's part of the big problem.
Thank you. And Ms. Erickson, as I mentioned, the allegations in this letter were brought forward by nearly a dozen whistleblowers, and more whistleblowers continue to come forward. In your opinion, are these issues with the New Jersey Sharing Network confined to this organization, or are these practices pervasive throughout the industry?
Sir, all OPOs are not the same, but what we have seen from this investigation is that too many OPOs are engaging in practices that are unethical and candidly illegal. Network for Hope operates in your state, and so I appreciate anything that Congress can do to ensure that they are immediately removed and patients are safe, that the allegations in New Jersey are investigated. And Congressman Bean, since you mentioned One Legacy, I want to say that they are, according to the data, one of the worst violators of harvesting human pancreata, and we don't know where they go. I want to be clear, these things are being done with taxpayer dollars, and wherever we know that there are problems, such as these 3 OPOs, I hope Congress can call on the administration to act.
Great. Thank you. And with that, Mr. Chairman, I yield back.
Thank you, Mr. Yuckin. Ms. Chu.
I want to thank all the witnesses for your testimony today, and in particular, I want to say how sorry I am to Ms. Knuckles for what horror your mother and your family experienced. And Ms. G, I want to address another horror that could occur to transplant patients, and that is what could happen to them if they lose their ACA coverage. In your testimony, you explained that transplant centers often will not even place a patient on the transplant wait list unless they have stable, continuous health insurance. I'm thinking in particular of one of my constituents from Sierra Madre, who is one of the longest surviving kidney transplant recipients in the entire country. He received his life-saving transplant decades ago and has been able to maintain his health because he's always purchased comprehensive coverage on the ACA marketplace, made affordable through the enhanced tax credits that Democrats enacted. But now, because Republicans refuse to extend those tax credits, his premiums for next year have more than doubled. He's terrified that he won't be able to keep his coverage and terrified of losing the transplant he fought so hard to preserve all these years. I also think of my friend and constituent who undergoes daily dialysis and is anxiously awaiting a kidney and is on the transplant list. But I think about what would happen to him and his wife if he is taken off the list because he loses his healthcare coverage. I know they would be absolutely crushed. So, Ms. G, can you speak to how widespread this problem could become if Republicans fail to extend the ACA tax credits before January 1st? How many transplant patients might be forced off the wait list or denied life-saving coverage simply because they can no longer afford the insurance that transplant centers require?
Thank you for that question, Congressman. First, let me say I'm sorry for the troubling situation that your constituents are in. Over 20 million people are currently receiving subsidies through the ACA marketplaces. On average, they will see their premiums more than double, increasing by 114%, according to KFF. In some states, premium payments will triple on average. According to the Congressional Budget Office, about 3.8 million fewer people will have insurance about 10 years from now if the expiring enhanced premium tax credits are not extended. As you mentioned, transplant centers commonly require that patients have an insurance in order to receive a transplant. This is to ensure that donated organs go to people where they will have a highest chance of success, and so people who are uninsured are commonly turned away or not listed for transplants. In the case of kidney failure or end-stage renal disease, there is eligibility for Medicare for people whose kidneys don't work or are undergoing dialysis or have received a transplant, but millions of other Americans will have no choice for affordable comprehensive insurance without the premium tax credits.
Thank you. And Ms. G, Republicans claim that people like my constituents and their families should simply switch to cheaper junk insurance plans or rely on high deductible HSA-based coverage. For these constituents that are transplant patients, being forced into a junk plan or high deductible coverage would simply not be adequate. It could actually also be dangerous. A missed refill or delayed lab could trigger rejection of the kidney that they waited years to receive. And you multiply this by tens of thousands of transplant recipients, then we would have a healthcare crisis for so many Americans. Can you explain why these plans are completely inadequate for transplant patients, how being forced into bare bones coverage could jeopardize their health?
Yes, so plans that are not comprehensive, including short-term limited duration coverage, association health plans, are not required to comply with ACA regulations. So this means that they can discriminate against people with pre-existing conditions, and that includes people with chronic diseases, with organ failure, or who have previously received a transplant. Non-compliant plans can do things like charge more or deny coverage altogether for people with pre-existing conditions. They may not cover essential benefits like hospitalization or prescription drugs, including the lifelong immunosuppressants that transplant recipients need, or rehabilitative services. They can also put lifetime or annual limits on coverage. And these plans also are not required to comply with the ACA's regulations on out-of-pocket maximums. In addition, high deductible health plans are, as the name says, plans with really high deductibles. They can reach up to $10,000 or above for family coverage. And that means that when someone needs a major surgery, including transplantation, or has a chronic disease or chronic condition, they may be faced with paying that full deductible out of pocket.
Thank you. I yield back.
Mr. Moran.
Thank you, Mr. Chairman, and thank you to all the witnesses here today for discussing this very important topic. Today's hearing highlights the information uncovered by this subcommittee's investigation into the fraudulent schemes operated by a number of organ procurement organizations that we've been referring to as OPOs. Reports from both this committee and the administration have begun to show that several OPOs have violated the trust of the American people and the law itself. Organ donation is one of the final selfless acts a person or family can commit for another person. However, several organizations have exploited this for personal gain and for financial gain. Let me be clear, Congress has a responsibility and a role to uncover the fraud, the waste, and the abuse here, and that's what today's hearing is about. We have a responsibility to expose wrongdoers. Ms. Martin, we thank you for your testimony and your courage to come forward and discuss the actions of your former employer. In your written testimony, you stated that following you coming forward as a whistleblower, the Health Resources and Services Administration, HRSA, launched an investigation. This was a key step in uncovering the fraud of the Kentucky Organ Donor Affiliates, also known as CODA. As a former OPO employee and one who blew the whistle on a bad actor in the industry, what is your advice to other folks in the industry who feel that they should speak out?
Thank you for your question. I just want to remind everybody that's working in an OPO right now, we are on the front lines. We are that patient's advocate. That's what we all signed up for, right? We have this great responsibility to the donor and their family and the amazing mission of organ donation and transplantation. So I would say to those whistleblowers, come forward. Don't be afraid. We are protected in ways, but at the end of the day, we're all here to save lives. We can't let this keep continuing to go on. Congress, please don't allow, whistleblowers to not be able to come forward. Make it safe for everyone. Make it safe for us so we don't lose our jobs, so we're not afraid.
Ms. Martin, I'll add that without brave whistleblowers like yourself and others that have come forward, it is hard for us to uncover the truth about what's going on the inside. You know as well as I do that only those that are on the inside day in and day out know all of the facts. And for you to come forward and give your story is very helpful for us to do our job here in Congress. So thank you. Following that investigation, HRSA uncovered 103 cases in which, quote, the organ donation process was initiated in error. You went on to say in your testimony that this was a systematic failure. That was the description you used that cannot be ignored. Ms. Martin, in light of your experience and the allegations against New Jersey Sharing Network, where should the committee focus its efforts on reform, and what kind of reform would you suggest?
So I think the biggest problem we have right now is not like who's in charge, but kind of looking at how we got here in the first place. So with OPOs running on kind of their own terms with no oversight, I think that it's important that, I'm sorry, can you repeat the last part of your question again?
Yeah, what kind of reforms would you suggest we undertake here as a committee to make sure that OPOs can no longer engage in this bad behavior, or that we can help with whistleblowers?
Thank you. So I think that we just all need to come together. You need to take into consideration the surgeons that are working, the people that are working at OPOs, hospital staff. Everybody kind of needs to sit down and kind of figure out where did we go wrong in the first place so that doesn't happen again.
Yeah, I guess even more specifically, where's the pain point? Who needs to feel the pain of these investigations so that they change their behavior and no longer engage in this bad behavior? And I'll ask the same question to Ms. Erickson as well. So Ms. Erickson, I'll start with you.
Well, I learned this from my military father. Leadership starts at the top. And the same organizations like Network for Hope, which Congressman Miller also operates in your state, cannot be allowed to abuse the public trust. They have to be immediately replaced. And I want to be clear about something. Many of the things that are being found by this committee constitute crimes. Medicare fraud is a crime. Lying to families about consent is a crime. So, Congressman, I really hope that this committee can work with HHS, State's Attorney General, and the Department of Justice to make sure that these executives feel the full force of the law.
Yeah, and how can we even go further to help protect the whistleblowers and to make sure that we are providing law enforcement the tools that they need to investigate the bad actors in the OPOs?
One thing I'd like to say about that is there is currently a federal contractor called the United Network for Organ Sharing, or UNOS, which has failed whistleblowers at every turn and ignored retaliation against them. It's even in investigative reporting that UNOS itself has retaliated against patient advocates. UNOS, when your previous colleagues in the Energy and Commerce Committee held a hearing, UNOS threatened witnesses testifying under oath with legal action at the same time they were being paid by the taxpayer to investigate their claims. That has to end. We have to stop all bad contractors, including those we know are retaliating against whistleblowers now.
Mr. Chairman, we're talking about overseeing the ability to stop profits from taking preference over lives. And we need to make sure that we put life at the forefront and make sure that it is essentially what we are protecting instead of the profits or the money coming through and the operations of these OPOs. I respectfully return my time.
Thank you. Mr. Miller.
Thank you, Mr. Chairman. And thank you to the witnesses today. We're here to ensure that organ procurement organizations uphold the highest standards in both their life-saving mission and their responsibilities as nonprofit entities. There are 55 OPOs, each mandated by federal law to perform procurement efforts in their donation service area as certified by Centers for Medicare and Medicaid Services. In 2024, there were more than 48,000 organ transplants performed, continuing a record-setting trend and representing a more than 55% increase in organ transplants in the last 10 years. In my home state of Ohio, LifeBank is one of the original 7 OPOs ever founded, with a service area covering 4 million people and working with 80 hospitals, including many in the Cleveland region. Maintaining the highest standards of integrity is paramount in organ procurement, chiefly to foster trust and to save lives, but also to safeguard valuable taxpayer resources for these critical purposes. For this reason, I'm concerned about reports that certain OPOs may be involved in alleged fraudulent schemes and improper actions related to their unique position as tax-exempt entities. As many OPOs strive to maintain and lift the integrity and standards of care at these life-saving missions, some challenges I have heard from my home state of Ohio include changes to the conditions for coverage that will affect the 2026 recertification process, such as evaluation of only one of the 4 years as part of the 4-year cycle, which may not account for process improvement efforts or overall performance. Concerns that the transplant rate metric reflects transplant centers' acceptance of organ offers rather than OPO performance, yet still heavily influences on OPO's ranking and chances for recertification. For example, data reveals a 29% kidney non-use rate per organ recovered per transplant. Evaluations may not account for geographical health, disparities, and environmental impacts. For example, diabetes is at a higher prevalence in Northeast Ohio, resulting in challenges in the donor pool and organ eligibility. Ms. Erickson, as you know, OPOs are certified by CMS to ensure the quality and safety of donated organs, including adherence to legal and regulatory requirements and to identify improvement opportunities. Unfortunately, we've been made aware of potential fraudulent mechanisms or manipulations of the system that could compromise integrity. Please describe the type of improper schemes that you may be aware of in the industry, as well as your thoughts on how to combat them, and would remedies like requiring transparency of the Medicare cost reports submitted by OPOs shed light on the issues of overbilling and unallowable cost?
Sir, they would. One of the most disturbing practices that happens at many OPOs is harvesting kidneys that will never be used in transplant. In fact, one industry insider gave a presentation to other OPOs about how they could differentiate between a financial count for kidneys and a clinical count for kidneys. That is another way of saying how to commit Medicare fraud. In fact, one whistleblower shared with Congress from Network for Hope that when their freezers were too full of kidneys that they could not use, they would take them to the University of Louisville Jewish Hospital and incinerate them. Part of the kidney harvesting problem is a problem of lying to families about consent and the fact that CMS will pay OPOs whether those kidneys are ever transplanted or not. This has to end.
I completely agree, and it's abhorrent, and thank you. Another question, Ms. Erickson. I understand there may be other practices that do not increase Medicare reimbursement but may assist the OPO in certification metrics reported to CMS. Can you describe what other actions may be occurring to improperly boost metrics that may not be readily available through Medicare cost reports?
Absolutely, sir. As your colleague, Congressman Bean, said, there is also the massive harvesting of human pancreata that do not go to help any patients either through transplant or research. This has happened to 7,000 American families who have been lied to, including in your home state of Ohio. CMS has said it will close this loophole, but it has not done so. And not doing that leaves every American family at risk, not only of being lied to about how their loved one's very body parts will be used, but also it could keep dangerous OPOs in place by falsely inflating their performance.
Thank you very much for your testimony and all the witnesses. Mr. Chairman, I have one more question I'll submit for the record. I yield back.
Thank you, Ms. Delphin.
Thank you, Mr. Chairman, and thank you to all our witnesses for joining us today. I really appreciate you taking the time and to share your personal stories and to shed light on issues within our organ transplant system. Each day, 13 Americans die waiting for an organ transplant, while more people are continually being added to the transplant list. I have the honor of co-chairing the Congressional Kidney Caucus with my colleague, Representative Carol Miller. As co-chair, I've had a particular interest in our organ transplant system. Specifically, I've worked to make living donations more accessible by proposing reforms to the living organ donation reimbursement program. Currently, living donors often face out-of-pocket costs exceeding $10,000 when donating. Bipartisan legislation that I've introduced would help address this. The Honoring Our Living Donors Act would allow more donors to qualify for wage, travel, and caregiver reimbursement when donating organs. And while these reforms should be implemented as soon as possible, more work is needed to ensure our organ donation system is operating well. Donating an organ is an incredible gift. one that should be treated with the utmost respect. Any conduct that disrespects that gift should be scrutinized immediately. Ms. Gee, what action should HHS, CMS, HRSA take to root out fraud, waste, abuse in our current system?
So I would encourage this committee, subcommittee, on a bipartisan basis to continue to investigate allegations, including whistleblower complaints that donor patients are being mistreated and OPOs are acting unethically, to hold CMS, HRSA, and HHS accountable. There's administrative action that HHS could take to ensure that donated organs actually make it to waitlisted patients in need. And specifically, HRSA and CMS should use existing authorities to demand greater transparency and compliance with existing rules. And they can terminate contracts when taxpayer money is wasted or patients are harmed. Those contracted OPOs could be replaced with existing contractors who have better track records of patient safety and quality.
Thank you. Every day, 12 people die waiting for a kidney transplant, and of those, there are clear disparities in transplantation rates among disadvantaged populations. It's incredibly troubling that Black and Latino patients with kidney failure are less likely to get a transplant. My understanding is that in 2024, nearly 12,000 potentially life-saving organs, including over 9,200 kidneys, were discarded in the United States. Ms. Erickson, you talked about this a little bit. What suggestions do you have for how to improve the kidney acceptance rate and ensure that every adequate and available organ is transplanted?
This is where data transparency is so critical, and HRSA has really led an effort here to make sure that all OPO data is available for public scrutiny and for CMS to hold its own contractors accountable. We can tell in the data, Congresswoman, how often OPOs show up to families, if they show up equally to families regardless of their race or socioeconomic status, how quickly they get there. These are all data that should be available and to which OPOs should be held accountable.
Thank you. And then we know that with less and less people having healthcare coverage, the challenges that folks are going to have accessing preventative care. If folks don't have preventative care, diseases may progress more rapidly. And as a result, with lack of insurance coverage, we end up potentially seeing a greater need for organs. Ms. Gee, do you have an estimate of what that impact will be in terms of increased need for transplantation because people aren't getting preventative care that may have prevented the need for a transplant?
So I don't have a specific number, but I do expect that we will see the opposite of what happened during the ACA coverage expansions over the next 10 years. The Congressional Budget Office predicts that the uninsurance rate in the US will go from about 8% to about 12%. And so some things I think we can expect to see are a smaller number of Medicaid insured patients being waitlisted for transplants, people having less access to care, people less likely to have a usual source of care. And we also know that many transplant centers look at the probability of patient adherence in determining eligibility for listing and eligibility for transplant. We know that Medicaid coverage is essential for reducing probability of eviction, for decreasing medical debt, and the ability to pay for prescription drugs and other forms of care.
Thank you. I appreciate it. Thanks to all our witnesses. I yield back, Mr. Chairman.
Mr. Swazi.
Thanks, Mr. Chairman, and the ranking member for holding this hearing today. Really appreciate you bringing attention to this. If you ask the American people what are the issues they're most concerned about today, they say affordability and healthcare as being two of the top issues that they care about. So the more that we can do to tie this issue into affordability of healthcare, I think the more attention we can get to this issue. I want to start by thanking the witnesses. I really appreciate you taking the time here today for telling your personal stories. It's a big hassle to come down here to come to this thing. You have to prepare, and the time that you spend, I'm very grateful to you for spending the time. We've heard everybody talk about it today. There's 100,000 people waiting for organs in the United States of America. And every day, as Congresswoman Del Bene just mentioned, 13 people die waiting for organs. And there's these allegations that you've all talked about and other people have written about of abuse that are taking place, that's costing a lot of money, that it's treating people unfairly, some really shocking things that we've heard in some of the testimony today about, people getting operated on when they're still alive. Scary things that are happening. I made a point of speaking to a constituent of mine today who I know is looking for a kidney. She told me she's been waiting 9 years. I mean, I'm going to dig into that further. I mean, how could it take 9 years? I mean, it's just hard to imagine. And I'm also concerned about this issue that we provide incentives and payments for harvesting the organs, but not necessarily the same for actually resulting in a transplant. And I want to just explore that with you a little bit. So my understanding is that there are 54 organ procurement organizations in the United States of America. And some of them do a great job. And some of them are really bad. And part of our hearing today is to try and highlight the ones that are doing a bad job so that we can hold them accountable. We heard about the one, and I think in Miami you talked about earlier, that's already been held accountable. And today we've heard a lot about Kentucky and New Jersey. So I just want to get clear. Am I right in what I'm saying, that we want to try and get CMS to hold Kentucky and hopefully New Jersey accountable? Ms. Erickson, you seem to be nodding your head. What do you say to that?
Yes, sir. And the way that CMS can hold them accountable is by immediately removing them and replacing them with higher performing OPOs that will do the job with integrity. They can do that anytime.
So some of the OPOs do a good job. They're not all bad.
Yes, sir.
And they're rated by the CMS. And for example, my OPO in my district, I called them up in preparation for this hearing. They had a very bad rating back in 2000, and today they're in some of the higher ratings. And they've dramatically increased the number of organs that they have both harvested and transplanted. So is there anybody else that we should be focusing on other than Kentucky and New Jersey right now? Is there anything that you want to call to our attention?
Yes, sir, absolutely. And we can even look at the CMS data and investigations that have happened across 4 committee investigations. For example, one of the largest OPOs operates in Los Angeles. It has been investigated by your Senate colleagues for harvesting human pancreata as part of fraud schemes. There are other OPOs who have been singled out for self-dealing and conflicts of interest that are also under investigation by your committee, such as Oklahoma. But sir, I think you're right that Kentucky and New Jersey are the 2 where there are just rampant whistleblower accounts that we have to make sure CMS acts on now.
Now, Ms. Erickson has talked a lot about pancreata. My understanding is that 80% of the organs that are sought are for kidneys. Is that accurate? Does anybody know?
Yes, sir.
That is accurate. Okay. So we want to just try and bring attention to this issue as much as possible from the stories that you've told, Ms. Knuckles and Ms. Martin and Ms. Erickson, and the data that you've provided with Dr. Gee, to try and hold the bad actors accountable and try and improve the system. Is there anything we can do to incentivize more transplants as opposed to just harvesting of data? Go ahead.
One thing, sir, is we can make sure that there is no such thing as a financial count for kidneys, right? The clinical count is what matters. The clinical count is what saves lives. The financial count, that's Medicare fraud.
So right now, it's my understanding that we spend between $500,000 to $2 million for every single transplant that takes place, from the harvesting to the placing to the transplant. And that's a lot of money that we spend in mainly Medicare, I think, but also Medicaid as well. And we have to make sure that the bad actors are held accountable so that this money that's spent is spent in an efficient way that actually makes people's lives better. So the more transparency that you've talked about and shining a light on this issue is a very big help to getting that done. So thank you so much, everybody, for your time again. Mr. Chairman, I yield back.
Thank you, Mr. Chairman, very much. And thank all of you for coming. Ms. Erickson, first of all, it's good to have a UVA graduate here. We always appreciate that. Excuse me one second. Ms. Erickson, I understand that your father was a Navy pilot who died of organ failure. You talked about it in your testimony, and buried at Arlington National Cemetery. with my parents, my grandparents. I'm fascinated by your testimony about the lack of oversight in terms of the pressured consent, trying to, people who could otherwise survive doing all this. What can be done to protect the whistleblowers, the people in the industry who come forward and talk about these abuses? What should Congress be doing to protect the whistleblowers?
Well, first of all, encouraging them to come forward, which is why I'm so grateful for this committee's investigation. But the other thing is demanding that HHS immediately fire any organ contractor that is found to have retaliated against whistleblowers, to have covered up their claims, and to have tried and silenced patient advocates themselves. There's been reporting in the Richmond Times, sir, in your home state and my home state too, about how the United Network for Organ Sharing has used its federal contract and federal taxpayer dollars to try and cover up cases and retaliate even against congressional witnesses. That this happens at all is a problem. That it happens with taxpayer dollars is unconscionable. So I'd appreciate anything this committee can do to make sure that HHS removes any contractor who's engaged in this activity.
It would seem the least they should be doing. Ms. Erickson, we have 3,000 Virginians on the Oregon waiting list. One, I think, is here today, Garrett Ertl, who's a living kidney donor and has served for years as chair of the Patient Affairs Committee in the Oregon Procurement and Transportation Network. He's been a tireless advocate for reform. You wrote in your testimony about literally some of these inappropriate OPOs destabilizing patients through the over-administration of comfort medications like fentanyl. Isn't this essentially trying to kill people in order to get their organs?
Yes, sir. I want to be absolutely clear. The things we are talking about are crimes, and they are currently being investigated by crimes by the Attorney General of Kentucky. And I hope that this committee will share all information with both federal and state law enforcement. Whistleblowers have made similar claims in New Jersey, and that is not just a danger to the people who live there, it's a danger to any American who travels through any of these states where whistleblowers have shared these practices happen.
It's frightening just to know that. You talk about the OPOs, the 990 is showing that more than $500 million was transferred to quote unquote related organizations. Who are they and why do they need the money? What's the function of these related organizations?
I'm glad you asked that question, sir. This goes back to the fact that CMS has to stop writing checks that it never looks into the use for. The Office of Inspector General more than 10 years ago found that the Los Angeles OPO, called One Legacy, had misspent dollars on football games, limousines, five-star retreats. And what did they do? They asked them to pay that money back. Then what did the OPO do? It opened a related organization and moved tens of millions of dollars to be farther outside of Medicare's control. We have seen, in fact, on publicly available 990s, as you said, more than $700 million has been moved in recent years. And it's hard to see how that's in patient benefit. And those are taxpayer dollars, and we need to understand where they're going and shut down these shadowy channels right away.
You write very well about the difference between organ donation and organ harvesting is consent. But you also talk about the potential coercion in obtaining consent. What does that look like, the potential coercion?
We've heard from whistleblowers in New Jersey that, candidly, sir, if a family looks like mine, ask once and then leave them alone. If they look different, if they look like they don't have resources, if they can't speak English, do not leave their side until they consent to organ donation. That is unconscionable. We need to hold them accountable for that. And also, back to what Congressman Bean said, no American family is consenting to their loved one's organs to be cut out as part of Medicare fraud, as part of exploiting the pancreas loophole. But that's what's happening. And so if there's one thing that I would really ask of this committee, is that it's to consider that these things are crimes. And just as there was cross-administration action to tackle the opioid epidemic, to resource not just the Department of Justice and OIG, but also state attorneys generals, that's the kind of crisis we have right now in organ procurement. Those are the kind of resources we need to make sure that Americans are safe.
Yeah, Mr. Chairman, thank you. And thank all of you very much for coming and bringing this to our attention.
Thank you, Mr. Meyer. And now you're stuck with me. A handful of questions I just want to sort of get my head around because I've read over certain portions of your testimony. We've actually been collecting articles for almost a year or two in regards to the technology, the subject. First one, is there a different scoring system between a kidney, a lung, a liver? Can anyone answer that? Is there a different hierarchy on both eligibility procurement, how it's processed, how it's provided to a patient? Ms. Erickson, can you answer that?
Sir, kidneys are treated differently when it comes to Medicare reimbursement, which is why the Office of Inspector General itself identified that the OPO reimbursement structure is so susceptible to fraud, waste, and abuse. And again, that's grim. The pancreas gets credit in terms of keeping your contract for metrics and scoring.
No, where I was curious is I was reading in one of the journal articles I have that lungs actually have sort of a different hierarchy of score. And that may not be as part of the reimbursement. It's actually on how they're processed and handled and procedured. Does that ring a bell with you?
Not in terms of how CMS considers OPO performance, but if there's another rating, I'm not aware of it, sir.
Oh, okay. In the hierarchy of a decision of someone has circulatory passed away compared to brainwaves pass away. One is 5 minutes, one is 90 minutes, but it is the hospital that makes that decision, correct?
It is the hospital that declares death, but one of the things that has come out through the HRSA's detailed report about Network for Hope and CODA in Kentucky is that often OPO staff get involved in that decision-making process in ways that they should not.
Okay, so at that moment, who is actually the to blame there? If organ procurement is hovering around, protocol is I have brainwave death, and that is 90 minutes. Ultimately, it is the hospital that is to make the declaration. Is it a shared responsibility? Is it the hospital's responsibility? Who actually, at that point, if you're the auditor,
Right.
who is actually to be held responsible?
It's the hospital's responsibility. I'll turn it over to Ms. Martin in a second, but I want to give one example of where there is a shared responsibility for what everyone is there to do. There is a case that's been shared with congressional committees out of Mississippi about Paula Dennison, which I'm sharing with permission of her family. In that case, a rural hospital in Mississippi declared brain death. Ms. Dennison's adult children agreed to organ donation on that basis. Now, let me be clear, that was a mistake the hospital made, but what happened next is unconscionable. Ms. Dennison was taken away by the Mississippi OPO, and she was cut into the next day to biopsy her liver, whereupon she started crying because she was not dead.
Is the term for that reanimate?
In this
Because I'm
case, no, sir,
uncomfortable.
this case was just, let me be clear, just a complete mistake. But what shocks the conscience is that for 19 hours, the Mississippi OPO did not call a physician. They did not tell Ms. Dennison's family. They kept documenting her responses to pain until she did not die. Her adult children then received a phone call while they were at a funeral home planning their mother's funeral. So to be clear, Congressman, did the hospital make a mistake? Yeah,
but
absolutely.
In that case, the OPO also did something
But the
outrageous.
OPO, in what world a human being doesn't call a doctor doesn't make sense to me.
Look, right now I'm also trying to just lay out that if we're going to do policy, the hierarchy of responsibility. Ms. Martin, you had a comment on, is my understanding correct, brainwave death, 90 minutes?
No. So
What is
there's the two separate pathways to donation. One is through a brain death
Could
donor.
you do me a favor? Will you, is your mic on?
It is.
Then pull a little closer, that's all.
Okay, so there's two different pathways to organ donation. The first is through brain death, and with those donors, they're just taken into the OR and they have the timeout and the operation has begun. The second pathway is through DCD donation. These are the donors that are brought to the OR. They're prepped and draped and they're extubated and given 90 minutes to about 120 minutes. It kind of varies depending on the hospital policy, but after that time that they have passed, when their heart stops beating, when they're in asystole, a declaring physician provided by the hospital will come in to declare death at that time after 5 minutes.
Okay, and so that's the declaration of death. The OPO has to wait, is there a period of time?
After they've been declared dead?
Yes, both.
So, so after the 90 minutes, there'll be a 5-minute hands-off period in which time the hospital-provided physician will come to make sure that the patient has died, and they'll declare death at that point. With brain death donors, death is declared as soon as the patient is declared brain dead by imaging or bedside exam.
Okay, thank you. That's actually helpful. We actually have been also exploring a series of articles on the cryopreservation of kidneys. You know, we've all been reading the articles of some of the genetic manipulation in swine, and even some of the attempts there to minimize anti-rejection drugs by some of the customization, and a fascination of what's happening there. We also, so we're actually, as a discussion on, for those of us in the Oversight Committee, it's more than just taking a look at organ procurement organizations. It's also helping CMS and others build a set of hierarchical rules, as the technology, we believe, is about to go through a revolution. We've already seen, a simplest example, think where we were a dozen years ago in liver transplants. And then a cure for hepatitis C came along, and the number of liver transplants changed remarkably. We actually had liver transplant centers around the country close because of the, Sovaldi and the cures for hepatitis C. We want to make sure we future-proof the policies that we're trying to encourage CMS, HHS, and others to adopt. So with that little bit of rambling, please be prepared for the next week or so. You're going to get some questions in writing. We've already had a couple members share that, and they will be made part of the record. And with that, I thank you for spending time with us today. And I really appreciate, because sometimes the stories are heartbreaking and hard to hear. Some of them, you understand the scale of the exploitation of the system. Ms. Martin, we've actually are digging into a couple things that were in your testimony of what looks like criminal fraud and exploitation of Medicare and Medicaid in the system. So thank you for everything you've all given us. And with that, the hearing is adjourned.